Welcome back, everyone. You're watching Medical Monday here on News Channel 5+. I've got Dr. Pat Whitworth joining me tonight. We've had a great conversation this evening and appreciate those calls coming in here on the Plus. And we're talking about advancements in breast cancer treatments, misconceptions, things to look out for. And let's go back into treatments. As we were talking over the break, we wanted to discuss why certain treatments over others, for instance, chemotherapy.
Well, you know, we use chemotherapy sometimes, and in fact nowadays we used it for a lot of time. We used it for everybody, or almost everybody, and we've learned now who really needs it, and it's a minority of patients. Now, we do some systemic treatment for almost everybody. By systemic treatment, I mean it's either a pill or maybe it's an IV, but it goes throughout the body. It goes other places besides just the breast. Why do we do that? It's because of statistics, really. There is, with any breast cancer, we can do some calculations, but we can calculate the chance that there's a cancer cell somewhere else in the body. And so if there's a cancer cell in a bone, the surgery, and if we do lumpectomy and radiation, those just treat the breast. That doesn't do anything about that cancer cell somewhere else. And we've gotten a lot better at this. We're still not perfect at it. Most people do not have a cancer cell somewhere else. But we don't have a scan or any kind of test right now that can tell us for sure. So if there's a significant risk of there being a cancer cell somewhere else, and depending on the patient, we can say there's a higher or lower risk, then we say we want that cell to die. We want to kill that cell. Sometimes we find it's a type that needs chemo to kill that cell that's somewhere else. Sometimes we find it's a type that just needs a hormone blocking medicine. If that cell is dependent on hormones and we block the hormones, that cell will die. So those treatments are given not to treat the breast so much, but to treat a cell that's out there, because if a cell becomes a tumor somewhere else, then we can't cure it, or very rarely can we cure it. So we want to sort of a preemptive strike before that cell can get out of hand. One of the big advances that we've had in the last few years is that these days, instead of just looking at how big is the tumor, we look at that tumor type, and if we see this is a tumor type that needs chemotherapy, for instance, or maybe that needs hormone blocking medicine, we'll give that medicine for a period of time before surgery. And with some of the most scary cancers, the ones that we scare people about, most are still cured, but we say, oh, this one's a little worse. With some of the scarier ones, we give that treatment before surgery and the tumor disappears completely. And it's sort of a nice test, you know, is this the right medicine? If the tumor disappears in the breast, we can believe it's probably disappearing if there's a cell out there. So in many cases, we give preoperative treatment just to, number one, make sure that that is the right medicine and that tumor shrinks, but sometimes because it changes something where we had to do a mastectomy into a lumpectomy, and that's kind of nice. These days mastectomy is a lot nicer than it used to be. We do
and that
often
is a scary word to a lot of folks too.
It is. We do what's called skin sparing mastectomies. I hope women haven't seen those old pictures of women that had a skin graft. We do skin preserving, and we also do nipple sparing mastectomies. So in a lot of cases, especially in a young woman who maybe has a gene abnormality who wants to have both sides mastectomies, we'll do a nipple sparing mastectomy with immediate reconstruction. Plastic surgeon does the first step in the reconstruction right then. And I love that situation when it happens, because a lot of times that woman's friends won't believe her. You know, it's the South, so she'll say, you know, I had to have a mastectomy, and they'll say, bless her heart, she thinks she had a mastectomy. I saw her, but she didn't have one.
She did opposite.
That's what, if somebody has to have that, that's what we want to hear. Kind
of that old way of thinking. Yes. I think it's incredible. You brought in some great information. Let's go ahead and anything else you want to touch base on that, about that post-operative, you know, again, that's also an important side of this as well. Well,
on the other end of the spectrum, you know, we are discovering cancers smaller and smaller and smaller. And we are still doing kind of the standard procedures. We've made big advances with lumpectomy, you know, and now, as we talked about, adding plastic surgery techniques to lumpectomy, lifting the breast a little bit, or doing a reduction, or using partial breast prosthesis in a radiation marker. But we are realizing that we're in many cases, kind of taking more tissue than we need to. And so there's a new device now called the Intact device, and it really was developed as a biopsy device, but it can actually remove a lesion. And we used it, and it's used mostly to remove just an abnormality on a mammogram. It'll remove it. Patients say, you know, you're going to do a biopsy, are you going to remove it? And you know, a lot of times we say, well, we don't need to, we'll find out. But this device can remove a lesion, and if it's one of those ones that has some abnormal cells that maybe aren't cancer, but they're on the borderline, you can remove that lesion with this little basket device. And what we've done in a study we did at several centers around the country is to use that for small cancers, because we're finding cancers that are, you know, 3 or 4 or 5 or 6 millimeters in size, less than 1/4 of an inch. And so we've begun to use that technique to do the lumpectomy, and we still can get the whole thing out with a rim of normal tissue.
You know, and again, bringing up lumpectomies again, we'll talk about this BioZorb again if maybe folks are just now tuning in, a device that we first introduced as we kicked off the show tonight. Incredible. This is really, it's a 3D marker that helps identify the surgical site after the removal of tissue. Kind of acts as a filler in a way, and this dissolves on its own. So it's an incredible, just another option that we have now. It's just, you know, again, the advancements is what we're talking about this evening. And then moving forward, you know, I think a lot of folks, one of the big questions, you know, the word cancer is a scary one, and a lot of folks want to know, well, what can I do to, in any sort of way, you can't always prevent it, but what are some things we can do? Exercise, eating healthy. You know, as a doctor, what's kind of your standpoint on this?
Well, lifestyle choices can impact risk, although they're all very difficult, you know. We know that the hormone-dependent cancers can be more frequent in women who are really over their healthy weight. If a woman is overweight, what happens is there's an enzyme in the fat cells of the body. That enzyme converts hormones from your adrenal glands into estrogen. So if you gain weight, your estrogen levels go up. Some women may have noticed that, you know, if they have some fibrocystic condition or some breast pain, if they gain some weight, their breast tenderness is greater. Their breast pain is more than it was before. So that estrogen level is sort of tied to your weight to some degree. So we don't think everyone should be too thin, but being in a middle range of weight, a healthy range, is good. I hear a lot of times people say, well, you know, cancers are dependent on sugars, but really all cells in the body are dependent on carbohydrates. That said, high carbohydrates has been a problem in this country for a while, because we went through a craze where we said avoid all fats, fat-free, low fat, and now we figured out in the last few years that was kind of a mistake, because what makes fat, you would think eating fat makes fat. Eating carbohydrates makes fat. So you want to have a good balance. You don't want to go to 0 carbohydrates, but sugar makes fat.
Yeah, it's all sugar's bad. Yeah, when it comes in the forms of pies and cookies, I guess. So.
But still, you can have a pie.
Okay,
and, you know.
We'll still have pie, room for pie. Yeah, I mean, that is great advice. I mean, of course, I think common sense ties in with, you know, the healthier we eat, the better care we take of ourselves, you know, the better outcome we will have. And now let's talk too about maybe the fact that, you know, when it is in a family, what's the best advice you have for, say, you know, a younger woman who maybe her grandmother or mother has been diagnosed with breast cancer? What would be your best advice? What would you like to see them do?
That's a very important question. I think, you know, we have advice for what women should do, but we haven't been giving them enough information about the fact that they can tell what their risk is, what their lifetime risk is. So I think every woman should get informed about her lifetime risk. And at St. Thomas Midtown, and now the whole St. Thomas system, throughout the advanced health system, we're moving toward calculating that lifetime risk when a woman comes in for a mammogram. As part of that screening mammogram, we calculate her lifetime risk, because again, if that lifetime risk calculates to be greater than 1 in 5, greater than 20%, we think we should add MRI as part of her screening in many cases. So there are several online tools, calculators that we can use. So that woman that wants to know, what should I do? I've got a strong family history, I'm concerned. she needs to ask her gynecologist or her doctor, her primary care doctor, can you calculate that risk for me? I really want to know what my lifetime risk is. And many of those doctors will say, sure, I'll do that. But some of them will say, I'm going to send you to a breast specialist. And a breast specialist should certainly be in a position to calculate that risk for that woman. And then she can tailor, does she need a little more screening than the average?
I think that is an important question to ask, kind of that early detection, going back to that. And how important, with all the advancements we've made, is it still vital? We always hear growing up as young women, to do those at-home exams, and a lot of times I don't think folks really know if they're doing those correctly. Is that still one that you all encourage doing? Or
we do, especially for younger women. Now it's controversial because mostly what you find are benign things that just scared the person. You gave them good news, you don't have breast cancer, but now you've got high blood pressure because we scared you, with this lump. But we do think, I think, and most breast specialists believe, women should check about once a month. And you're not looking for a little change where you say, is that different? I can't tell. You're looking for something where you say, wow, that's different. And when you have a change where you say, man, that's a real difference, then you should check that out for sure. It's still mostly going to be a benign change, but if it's something, you can catch it early. The challenge with young women and the challenge with denser breast tissue in general is that it's very hard to diagnose compared to a woman who has a less dense breast or an older woman. As a woman ages, 50s, 60s, and 70s, that glandular breast tissue changes to more fatty tissue. Well, fatty tissue on a mammogram is black, and cancers are white. They stand out. You can easily find those on a mammogram in most cases in a woman in her 60s or so. In a woman in her 40s, it's very hard, and that glandular breast tissue looks white on the mammogram. Cancers look white. You can't find a polar bear in a snowstorm until it gets to a certain point. It scares these women to death because they think, well, it wasn't here yesterday, and now today it's this big. But that just means it kind of crossed the threshold where you could feel it.
Okay.
But that once-a-month self-exam is important. Certainly the once-a-year exam with your specialist is important too.
Just a few more minutes here before we break again. I wanted to ask you, you did touch base on the age spectrum. How do you go about things differently with, from a very young woman in the treatment and maybe some of the care? Of course, both are of most importance equally. But how do you have to do things a little differently? Say someone who more leaning towards an elderly age getting diagnosed versus someone in, maybe their early 20s, mid-20s, kind of in the younger end of the spectrum?
Well, things are changing. Things are sort of changing all the time, but we have gotten very, very comfortable with the lumpectomy plus radiation approach. The results are very good with some of the techniques that we're talking about. So more and more women in their 50s, 60s, and 70s are making that choice. Younger women, the survival chances are exactly the same, but they're also worried about having another event in a lot of cases. You're going to cure this, and if something else happens, you're going to find it way earlier than this, so it's not, you're going to cure that, but what's my risk? So if a woman has one of those gene mutations, we start to think about the nipple-sparing mastectomy approach instead of the lumpectomy approach. So a younger woman with a gene mutation, no doubt we start thinking about that a little more. And a younger woman in general, we start thinking about genetic testing a little more. It's a little more difficult to diagnose in those folks. So a young woman with a complicated exam and a strong family history, we're very pleased that usually we calculate that lifetime risk. It's over 20%, and we can get an MRI to really help us sort that out.
Incredible. I think too, just kind of, surgery always, it can be a little harder on someone, in an older age, but again, those advancements and the things we've been talking about tonight, we have definitely come a long way. All right, well, lots to talk about tonight. Dr. Pat Whitworth, we appreciate you joining us tonight. We're going to go ahead and pause for one more quick break. Keep it right here on News Channel 5+. And if you do have any questions, stories you want to share, comments or concerns, feel free to call in. I'm going to go ahead and give you that number before we pause for break again. It's 615-737+. That's 615-737-7587. We'd love to hear from you. Any questions you may have tonight, hopefully we can get those answered for you. Keep it right here on News Channel 5+. We'll be right back.